taken up the fluorescent dye, and it shows up as a separate population because of increased fluorescence due to RNA content. Now, a lot has been already known about HFC. Studies have been done in the context of infectious illnesses where HFC was high in dengue fever. Several studies. Why did we decide to look into this in our hospital is because clinicians started, randomly calling, like, can you tell us what the IPF is? And it would stop there. They wouldn't even ask, like, is it significant, or till when will we wait? Does it actually change anything in their, in their management? Then some of them came up to us asking, do we have HFC here? Can we do an article? And this is mostly the mid-level faculty who probably are in line for a promotion and they want some research articles and something, can be easily done with less effort. Then from the laboratory side, what we faced were fever with thrombocytopenia with the typical dengue scatter pattern and HFC values, which turned out to be not dengue, or they just stopped the analysis with dengue NS1 antigen or the card IgM IgG. They didn't pursue it with a sensitive platform. So we never knew whether it was truly not dengue or not. So we looked into this. So it is a pilot study, an observational study, 1 month prospective, 2 months retrospective. We took cases of acute febrile illness, the infectious group, and the non-infectious causes of atypical lymphocytosis. So we wanted to see if there's any correlation with the morphology with HFC, and if you can differentiate the various causes by looking at HFC and scatter pattern, and also if we can determine a lab cutoff to distinguish dengue from non-dengue cases. So this is the 171 cases that we had and the split up. Most of it were dengue, and we had leptospirosis, infectious mononucleosis, H1N1, few cases of malaria and scrub, but I have not included the analysis of scrub in this talk because the scrub results that were coming, most of it were like, people, even the microbiologists were like, it could be a cross-reactivity. And the cases that were indeed followed up with a DNA PCR all turned out to be negative. So I have not included that. So we had a total 73 cases of dengue, and the ones which had an NS1 positive were 65 cases. So in the first sample, we just looked at the first sample that came to our lab, that is of patients with a febrile illness less than 10 days. First sample, we took the mean of the HFC and it was 4.95. When compared with normal controls, it was significantly higher. And this was the various patterns that, this is a pattern that we saw with varying degree of HFC percentage. Now, morphology-wise, it was predominantly the type 3, but we would see type 1 and type 2. It was mostly the bluer and the more immunoblastic type. Now, 8 out of 73 cases, when it was NS1 antigen and IgM IgG by card was done, it came negative, but it was positive on the sensitive platform. In these cases, our HFC was high and the typical scatter pattern was there. So when we saw this from the lab side, and we saw that the NS1 antigen and the card IgG, IgM came negative, we had asked them to follow it up with the alpha because we went by the pattern and the HFC. Now, we just, out of this 73, we took out a small subset, which is 24 patients with severe thrombocytopenia and had minimum 5 serial values for monitoring to see about the platelet recovery in relation to HFC. And we noticed that most of the patients, most of the cases showed a platelet recovery within 24 to 48 hours. Now, coming to the next group, 23 cases of leptospirosis. It didn't have a very significant high HFC. In 2 cases that was showing very high HFC values, the first one actually had a complicated illness and severe thrombocytopenia, developed shock. So he had a more, it was a more morbid condition. And the second case was a case that had a dengue NS1 positive outside. And in our hospital, it was negative and leptospira serology came positive. So I don't know whether it's cross-reactivity or it's a dual infection here. Infectious pneumoconiosis, we had 14 cases. Here we had a higher HFC, but not as high up to what we see in the dengue cases. And this is the various patterns that we noticed on the scattergram. And coming to the morphology, it was predominantly type 2 cells, though there was few of the type 1 cells too, morphology cells. 27 cases of H1N1 was analyzed, and we got an HFC mean of 0.68, with one case that went up to 4.5%. And this is the morphology that we saw. It was varying between type 1, type 2, and type 3. And this was the case of H1N1 infection with the high HFC of 4.5%. This patient developed over the course of his illness, he developed multiple problems and he went into sepsis, septic shock. He had serial drop in counts, and so his course of illness was severe. So this made us think that those patients who don't do well, who actually develop a severe illness, it is reflected in their HFC count, though this has to be evaluated in a larger group of patients. Now, in malaria cases, we had a mean HFC of 1.5%, higher than what was seen in normal, but not as high as dengue cases. I've just highlighted a few. Some of the cases were mixed infection, ring forms, and the HFC varied from 0.4 to a high of 3. And I kind of noticed that there was an inverse relation between the HFC and the infected red parameter that comes on the Mindray, so which made us think that maybe when the immune response is more, the parasite load comes down, if that can be taken or understood from this. So the next group where we were getting fever, thrombocytopenia with reactive lymphocytes was the next group was the autoimmune disorders group, which there were cases with fever, thrombocytopenia, and reactive lymphocytes. And this is just a tabulated profile of these patients. 3 of them were diagnosed cases and they were on treatment, and they presented with either bicytopenia or thrombocytopenia, and the HFC values range from 0 to 0.8, not that high. But then we had another 3 patients who were diagnosed it was an acute presentation of the autoimmune disease in the form of recurrent oral ulcers, alopecia, SLE, or a rheumatoid arthritis with severe symptoms. So in these cases, the HFC percentage was found to be higher, ranging from 3.2 to as high as 11.7. So I am just highlighting this case. It was a young male, a 28-year-old male patient, and we got the CBC. It was showing thrombocytopenia. There was, it was mild thrombocytopenia, but there were a lot of reactive. This is the spectrum of lymphocyte morphology seen in this case. It was all over the place. And when we looked into the scattergram, it was showing the typical figure of 8 appearance with a high HFC of 11.7. So when at the first day we were telling, please evaluate for dengue, exclude that, and the clinician did perform the dengue testing for the dengue, and it came negative. We told him to pursue with the sensitive platform alpha, and that also turned out to be negative. Meanwhile, over the course of the next 2 days of this patient, he developed skin lesions which was quite diffuse and erythematous, and they had a query of SLE, which is actually quite rare in male, and they worked up with an autoimmune profile which was showing a pan-reactive panel. So the diagnosis was acute flare SLE with myositis. And here we got a high HFLC count. And in an ITP newly diagnosed before treatment started also, we see the same pattern with a high HFLC count. Now, coming to the non-infectious group, there was a total of 26 cases which have been segregated. Bulk of it was the CLL. Here, the HFC was not that high. We had 4 cases of hairy cell leukemia. Again, the HFC mean was not high. 1 case of adult T-cell leukemia lymphoma, HFC not high. And Burkitt's leukemia, which couldn't show any differentiation on the scattergram, no value. 3 cases of multiple myeloma, which had plasmacytoid lymphocytes in the peripheral blood. This was the morphology seen in our cases. And the HFC pattern, it ranged from 0.5 to 1.1, and we see plasmacytoid lymphocytes in the peripheral blood. There was 1 case who was a relapsed myeloma, and she had plasmacytoid lymphocytes in the peripheral blood, but her course of illness, she had developed sepsis and she expired. So all these findings based on our observations, in the infectious group, dengue has shown the highest values, but in the non-dengue cases, if you see high HFC values, it would suggest that there is the symptoms are more and the course of illness is high, like in sepsis, and the morbidity is higher. So we have a central laboratory concept. So the microbiology sits just opposite to us. So whenever we see these patterns, we go and correlate with microbiology results. And when they saw that we would tell that it was dengue before they even do the test, they approached us because they had an ongoing project for finding out the serotype of the dengue in our area, dengue virus in our area. So the problem they were facing was that the sample, they would like to identify them as fast and rapid as possible so that they can extract the RNA and before the dengue virus clears off from the system and before the sample tests positive after the clinician request. So this is how we have been using this HFC and the scatter pattern. And also in the autoimmune cases, those who present with acute flare or that acute disease manifestations have a high HFC, and if it's controlled, it comes down. So a potential for monitoring response to treatment can be considered. This would be, we would like to study a larger cohort in order to, make sure that these findings have any relevance.